What's up, boys and girls? So this is Paeds Advanced Paeds review. This is assuming you know most of the stuff, and we're just going to push you from like a 245 maybe to a 255. So this is just neonatology. I'm going to start an entire section on Paeds, but this is neonatology. I'm not going to waste your time. First step 2ck. Anyways, moving on. First thing that I want you to know is neonatal resuscitation. Generally, there's not a question on this on UWORLD. Just remember that the target heart rate is more than 100 and respirations are between 40 and 60. The thing is that if the heart rate's less than 100, it kind of changes what you do. The first thing, if the heart rate's less than 100 but above 60, we assume that it's the lungs that are messed up. So you're going to positive pressure ventilate these kids, or you're going to choose the option that says bag and mask ventilation. Anyways, so heart rate less than 100, positive pressure ventilation or bag and mask ventilation, we're assuming the lungs are a problem. If the heart rate is less than 60, we're going to assume that it's the heart itself that sucks. So we're going to start CPR, that compression technique. They're going to tell you 2-finger compression or yada, 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 whatever. Or you're going to choose umbilical vein catheterization for epi. So if everything else is good, so if heart rate's above 100 and respirations are between 40 and 60, this means baby is good. What you're going to do is you're going to choose the option that says like give contact with mom or put on mom's chest or wrap and blanket and put on mom. Don't choose the option that says give like vitamin K or like NG prophylaxis, like Neisseria gonorrhea prophylaxis, go like erythromycin in the eye, yada yada, or Hep B vaccine or neonatal screening. The thing is, those things usually can wait. So if there's an option like of giving contact with mom, just choose that option over immediately jumping towards like the things that we do in routine newborn care. Those are the points I want to make about this. Okay, so moving forward. This is again, just I put it, you can pause the video, take a look at this. This is like the routine stuff. Generally, we do this before discharge from the hospital, so we can do it within 48 hours. You don't have to do it immediately as soon as the baby's born. Okay, so just to point out, you probably already know what symmetric and asymmetric fetal growth restriction is. Just for you, fetal growth restriction is when they're less than 10% for their gestation. What I wanted to point out here is that if you check it out, like symmetric is obviously like chromosomal, whatever, you guys know that. I wanted to point out that uteroplacental insufficiency causes asymmetric, so preeclampsia, whatever, right? Gestational hypertension. I wanted to point out that maternal disease is here. So if they give you like maternal malnutrition, if they give you that mom's smoking drugs, like look at this, like this is the mom's hand, baby's hand, he's smoking something. Just remember that it's here. Drugs, NSAIDs, ACE inhibitors, all of the substance abuse is generally here. I just want to point this out. People get this wrong. So remember that it's like uteroplacental insufficiency with preeclampsia and whatever, but it's also maternal drug abuse, maternal like pharmacological drugs or like drugs of abuse or everything. And then the second thing I wanted to point out is diabetes. Babies, like moms of diabetes, have like babies that spares the abdomen. Usually in asymmetric FGR, we see that the head is really big, right? And the abdomen is really small. It's head sparing. But in diabetes, remember that there is a possibility that there is abdominal sparing effect. So the abdomen might be pretty distended. That's just something just to keep in mind. Sometimes they'll give the abdominal circumference of like 97%, head circumference of like 2 on the percentile. Remember that that's diabetes. It's gestational diabetes mellitus is the option to look for there. That's like just one of the flip cases. Everything else, like you guys already know. So next thing, Erbs Duchenne, you guys already know it. Just the reason that the slide is up here is associated with phrenic nerve injury. So they'll give you like a diaphragm, which is like this or whatever, right? And just remember the treatment like resolves in 3 months, doesn't resolve 3 to 9 months. So you guys know this. Just remember phrenic nerve injury is the association with this. Next one is Klumpke's. Again, I just put this here just because we did that one. The thing is that it's associated with obviously the Horners. So Horners because like it's the lower tracts that are getting affected. Again, there's going to be no grafts, no biceps. Those are going to be present in what the hell is the name of that thing? Whatever, you guys are, I forgot. Okay, now and then I will assume you already know all of these things. I just want to get out into detail on transient apnea newborn, neonatal RDS, and persistent pulmonary hypertension of the newborn. What I wanted to show is, so look at this little nice ass x-ray that I've put up for you guys here. Now, obviously, they don't ask you to identify just an x-ray, but I just point out that what do you see, right? So you see like ground glass opacities, like that's up here. Do you see how it's like all white and hazy? Over here, when there's like shit down here, this is interstitial edema. And generally, if you see, right, we can see do you see how we can see like this tract-like pattern? I'm going to clear it. So do you see how you can kind of see the bronchioles? So this is air bronchograms, interstitial pattern, ground glass opacities. The reason I put this up here, right? Let me get back. So this is neonatal respiratory distress syndrome. Usually you will have the stem to make the decision, but like see the air bronchograms, right? That's the one I kind of look for in the ground glass appearance. The thing is, right, they're going to ask you what to do about this. And what majority of sorry for like the church in the background. They're going to ask you what to do about this. What you want to do about this, right, is everyone will choose intubation with mechanical ventilation surfactant. That is the wrong answer, right? Very like if the right answer is continuous positive airway pressure, you're just gonna have, man. I'm gonna pause. I'm gonna come back when the church is not pooping. Okay, man. The church shut up. Anyways, my point here is, right, the point that I was trying to make is intubation mechanical ventilation surfactant is technically the correct answer. But if they say give CPAP or non-invasive positive pressure ventilation, or they say positive pressure ventilation with the PEEP, yada yada yada, remember, choose that option first. That is a little more conservative, and then you're going to go to surfactant. Everyone just tries to give surfactant. Okay, next one. This is a chest X-ray of persistent pulmonary hypertension of the newborn. Remember, I didn't include one for transient tachypnea of newborn because that's just like you see the perihilar streak. This is the one. Just see that like the entire lungs are really messed up, and you see they also have cardiomegaly sometimes, and we say that they have interest. So I'm just going to read out the description. So I'm reading out the description for this. See if you can spot it. Cardiomegaly with moderate pulmonary vascular congestion and mild interstitial edema due to cardiac etiology or shunt. So that's there. There's shunting happening in, like, that's the basic pathophysiology of this. And then the second is this is after they've treated a bit, and like these spaces have widened out a bit, and the heart is, well, still like a little bit big, but not as big as that one there. Anyways, I just added one. They're never going to make you like identify one directly from these, but it's just good to know, right? There, it looks messed up, but it doesn't look messed up like how RDS looks messed up. Okay, next one. So this, I've just added the causes here. What I wanted to point out is this is how you treat. You give a pulmonary vasodilator. This is something that people just kind of forget, right? And loud P2, yada, yada, yada. But like, you can pause and just look at this. This is from UWORLD. Okay, the next thing. This one, okay. So you're going to recognize that it's a congenital diaphragmatic hernia. They're going to tell you it's a scaphoid abdomen. They might show you bowel loops and whatever, right? What I want to point out is the management of this. So what you want to do is, ideally, if you think about it, what you want to do is you want to decompress the bowel, and you want to put an endotracheal tube and make the lungs go big, right? So they're going to put in an option. They're going to say, and like they're going to give a kid who like can't breathe, who has like pulmonary issues. They'll give you a saturation maybe like 82, 81, 67, whatever, right? So you're going to freak out, and what you're going to do is you're going to choose bag and mask ventilation. The thing is, bag and mask ventilation is contraindicated. The thing is, if you put a bag and mask ventilation here, you don't know if you're pumping air into like the lungs, which are fucked up, or the like the esophagus and like the stomach. So the point I'm trying to make is you're going to put an ET tube down. So you're going to make sure you're ventilating the lungs. You're going to put an NG tube in, and you're going to start suction, right? So the point I'm trying to make is bag and mask ventilation, or like over the mouth ventilation, is contraindicated. You need to put an ET tube, and you need to put an NG tube, and then you're going to ventilate and decompress like there. So that's whatever in here. You can pause, you can read this, and just take a look at it. But that's like the point I wanted to make. Okay, moving forward. Okay, so interventricular hemorrhage. Obviously, what they always sometimes ask is like, oh, you'll recognize that it's an interventricular hemorrhage. First of all, the baby will be preterm or like really small. What I want you to realize is that if they're generally less than 32 or less than 28 weeks of gestation, we do routine screening, right? So, and how do we screen for this interventricular hemorrhage? We do like a cranial ultrasound through the open fontanelle. The anterior fontanelle closes routine like 15 and 18 months. So we do that till then. Anyways, we screen them at birth. That's my point. That's the first point I wanted to make. The second point I wanted to make is if they ask the mechanism, right, you're going to say germinal matrix fragility. That's like the choroid plexus thing. And what you want to remember is babies, especially preterms, can't auto-regulate. If you remember, like from the renal physio, there was auto-regulation going on, whatever. Even if you don't know that, germinal matrix are those friable vessels in like the choroid place. And they can't auto-regulate, so they burst and they cause this interventricular hemorrhage. So I wanted to point out, so prematurity, low birth weight, and the third one is vitamin K deficiency, which basically all babies are when they're born. And I want to point out that this is early vitamin K deficiency. So early vitamin K deficiency will cause interventricular hemorrhages, and late vitamin K deficiency will cause bleeding inside the gut, right? Anyways, okay, moving on. So, okay, this is just a picture of it. This is like, just take a look at it, pause it, take a look at it yourself. Okay, next thing is management for necrotizing enterocolitis. What I wanted to point out here is, again, these three antibiotics. And it's kind of the same idea. First of all, like, know how to recognize it, you probably know, but like indications for going in is something what I wanted to point out. So if you see pneumoperitoneum, if you see peritonitis, lactate, this is kind of very similar to the inflammatory bowel disease, the reasons that we go in. But check out this portal venous gas. If you see this, this is an indication to go in and just cut it open and cut out whatever the necrotizing part is. The reason I put this in is this is what I wanted to show you. So check this out. This here is pneumoperitoneum. Do you see this air like right here? That's pneumoperitoneum. Apparently, they say that there's pneumatosis intestinalis over here, and like I don't know, I don't see it. I don't know if you see it. But the reason I put this up is look at this liver. Do you see anything in here? Check it out, man. Check it out. Do you see this tract that's going along? This is portal vena. This is air in like the around the biliary tree and shit. So I'm gonna clear it. Just take a look at it. Do you see? So if you saw this X-ray with a kid with necrotizing enterocolitis, you're going in. So you're choosing laparotomy, right? Okay. So just know that. This is again just arrows. You can take a look at it. You can pause the video, take a look at it. Okay, next thing, apnea of prematurity. I assume you will probably know. What I want you to know is when it's not apnea of prematurity. So the first thing is when it happens in the first day of life. That's weird. It shouldn't happen then. It should start generally at the second or third day of life. The second thing is just read all of these, but like this one is the one I wanted to point out, that when it starts at the first day of life, that's probably not apnea of prematurity. They should be well appearing. Like you'll get the feel that it's apnea of prematurity, but that's just one concerning symptom right there. Okay, next. Okay. Oh shit, I didn't clear the. Okay, this is something everyone gets wrong. Well, the reason that they get wrong is, first of all, when they'll give you a gonococcal conjunctivitis, they'll say there's purulent discharge. They'll ask you how to treat. Everyone will choose oral erythro for some reason. Remember that to prophylax against Neisseria gonorrhea, you're going to give topical erythro. That's for prophylaxis. Or topical tetracycline. That's for prophylaxis when they're born. Later on, you're going to treat with the cephalosporin and intramuscular cephalosporin. You're going to give an intramuscular to the kiddo. Remember, don't give ceftriaxone. The reason you're not giving ceftriaxone, you're going to give some other third generation cef, but not ceftriaxone. The thing is, ceftriaxone displaces unconjugated bilirubin from albumin, and when you displace the unconjugated bilirubin, it can cause hyperbilirubinemia and can cause kernicterus. Just remember that. For more intents and purposes, you're never going to give ceftriaxone. So remember, gonococcal, you're going to prophylax with the erythro, but you're going to treat with ceftriaxone. For chlamydial, you do not prophylax and you treat with a per oral erythromycin. This is just something people mess up. Just know this. Okay, moving on. Okay, I'm going to assume you know all like the UWORLD table of the neonatal rashes. This is just another one. This one's called cutis memorata. Like this is this lacy. I'm just going to read the description from what I have here. It's cutis memorata. Risk factors are a low gestational age, hypothermia, asphyxia, hypoxia. It's a lacy reticular rash. Just know the name of it, I guess. Like I will assume you know all the other ones already, which are these. Just know the name of it. And just another thing sometimes they'll tell you that the rash has eosinophils in it, and if it has eosinophils in it, that's erythema toxicum neonatorum. So just know these, man. Just know these. These suck, but know them, right? And add one to your like mind. It's cutis memorata. Okay, next. So this is treatment of cleft palate. This is really easy. These are pictures. Just remember, lip you treat early, 11 to 12 weeks, and palate you treat late, 11 to 12 months. Just remember this. Okay, next thing. Okay, jaundice. This is a lot of people. Okay, a lot of like I don't know. You probably know this, but just people get this wrong, right? Physiological jaundice. Okay, starts second to third. So kind of like apnea of prematurity. It starts a little bit late. It peaks. It disappears by the 5th to 7th day, and it peaks at the 2nd or 3rd day. Remember that 13 is the high number there, and less than 5 milligrams like per day is the rate of like increase. Pathological jaundice is anything above this. So first 24 hours, you're going to suspect like ABO, like incompatibility, or like the rhesus antigen thingy. And if it's growing above 5 per day, so they'll give you like 12, and the next day they'll give you like 19. So now you know it's going above 5 milligrams per day. That's a big problem. And then peak, obviously the peak can be anything. Okay. So what I wanted to add something. Wait a minute with this. Okay, I didn't write it. Anyways, whatever. Biliary atresia. The reason I put this here is what's the gold standard test? Everyone's going to choose liver biopsy, but you're going to be smart. You're going to choose the gold standard test for this is different. It's intraoperative cholangiography. You're going to do an ultrasound. You're going to see that triangle cord sign, the fibrous remnants across the porta hepatis is like the fancy buzzword. You're going to do a liver biopsy. You're going to liver biopsy them. It's not like you're not going to biopsy them. You're going to biopsy them, right? And you're going to confirm the diagnosis, and you're going to refer them for like the Kasai procedure, the hepatoportoenterostomy. But you're going to intraoperative, like if they ask for the gold standard test, it's this intraoperative cholangiography. Just I don't know. Don't get it wrong. Okay, this is the reason I put the thing two slides ago. Phototherapy above 20, exchange transfusion above 25, right? It's not like phototherapy above 20. In phototherapy, you want to remember that you're isomerizing the bilirubin. You're not breaking it down, yada, yada, yada. And phototherapy only works for an indirect hyperbilirubinemia. All the times you're having problems is the indirect bilirubin. Direct bilirubin doesn't like go to the brain and shit, right? So phototherapy above 20 and exchange transfusion where you're literally taking out their blood and giving them new blood, that's at 25. Okay, next. Okay, so this is just remember like why I put this here is like notice how there's hypotonia here and hypertonia here and know how to recognize them. Yeah, I'm not gonna go into it. You can pause and read this. Okay, this is just the one that like we don't really care about much, but anything that causes like folate deficiency, like generally we think about phenytoin, but valpro anything can cause fetal hydrantoin syndrome. Now, like just remember the features. Intrauterine growth restriction, well, that's kind of non-specific. So this cleft lip, carbamazepine also causes cleft lip. But what you're going to look for is like the hypertelorism, the fingernail issues, the phalanx issues. Look at these fingers, guys. Just look at them, right? And excessive body hair. So this is just kind of something you want to look up. Take a look. Let me see if I'm missing something. Okay, so I'm just gonna actually never mind. Okay, moving on. Okay, vaccine shit. What I want to point out is rotavirus is the only live vaccine we give at the age less than one. Everything else, like the MMR and all that stuff, comes at one. So this is the only one we give before one. It's a little bit weird, but just memorize it. We give a series between 2 to 6 months. There's the 2 dose and a 3 dose series. Remember, intussusception, skid anaphylaxis. People forget that Meckel's diverticulum is also a contraindication. So what they'll give you is someone with like he has a history of like Henoch-Schwerin purpura with like IG with like intussusception, right? At the age of like 4, you'll be like, all right, or like complicated Henoch-Schwerin purpura for which he needed a barium and like enema or some shit. Just understand that means like intussusception and whatever, and that's a contraindication. And Meckel's like a known Meckel's diverticulum is a contraindication. So just remember that, I guess. Next thing, egg allergy. A lot of people are freaking out about these questions, man. The only thing that, if you have an egg allergy, the only thing you can't give is yellow fever. Everything else you can give. People, there used to be egg in MMR, there used to be egg in influenza. There's not anymore. You can give them egg allergy. Only thing you can't give is yellow fever. And just another thing to remember is that inactivated like influenza, the IM shot that we give in like clinic, that contains thiomersal. If you get it from like, so there are two types, right? So like there's this type of influenza vaccine that comes in this huge ass vial and you can like take shots from it. Like it's not individual. Like there's a vial with like 50 doses of influenza like vaccine and you can just keep on like loading up a dose and giving it to people. That one contains thiomersal. Some people are allergic to thiomersal, so you can't use like the big vial that you have. You can use the individual influenza packets if you want, but like this is not something super high yield. Just know it, I guess, that some influenza formulations contain thiomersal. Let me see if I'm not. Okay, I'm not. Okay. Okay, so next thing, man, they're gonna tell you that the kid got a vaccine, he's now ill, yada yada yada. Remember that like this is the normal reaction to vaccine. You can still give a vaccine. Basically, if you're not giving a vaccine, right, you should be 100% sure for a reason to not give it. Just general advice. Um, this is an abnormal reaction. So memorize these. So this is when you don't give the vaccine. Another thing I want to point out: live vaccines can be given together. Generally, this is not recommended, but technically you can give them together. And another thing, this is the shit that people know. This is the reason I made this slide. If they get IVIG, right, they can't get a vaccine for 8 to 12, like 8 to just a year, So if they get like Kawasaki, if they get like I don't know, man, TTP or some shit, man, it's probably not common in kids, but if they get IVIG, you can't give them a vaccine for a year. Live vaccine, you can't give it for a year. Just remember that. Okay. Okay, this one I really like. So hepatitis B is at birth. Okay, everyone knows that. Just a thing to know is, oh shit, sorry. Just a thing to know is, oh yeah. So here's like you can technically give live vaccines together, but you generally give them 4 weeks apart. What I wanted to point out here about hepatitis B is hepatitis we give at birth, right? It's one of those ones that we give at birth before the kid leaves the hospital, yada yada. You cannot give it if the infant is this small. If less than like 2 kilograms, the baby's too small, you can't give it. The reason is because they don't develop antibodies. So when do you give it? You give it when you're discharging these really small babies from the hospital, right? At that point, their weight doesn't matter. You just don't give it when they're less than 2,000 like grams, like 2 kilograms. You give it at age 1 month, regardless of birth weight or when they're discharged from the hospital. So basically, just make sure you just look at the. Anyways, if like a less than 2 kilogram baby is not jumping out at you, man, there's something wrong with you. Okay, moving on. Um, okay. So, if mom is Hep B positive, everyone has memorized that you give vaccine plus IVIG, right? That's everyone knows that, right? If mom is Hep B unknown, that's the reason I put this up. If mom is Hep B unknown, you're going to give the vaccine, so which is HBV vaccine, whatever, and you're going to check status of mom. If mom's titers, and you're going to check status with like the IgM of HBC and like whatever you check. And if that comes back positive for mom, like either mom has active like RNA or active IgM HBC, you're gonna give IVIG. Then if not, like you're gonna hold back on IVIG. Okay, next. Next. Okay. Obviously, everyone knows this exclusive breastfeeding till 6 months. Everyone knows the second thing as well, that it contains all the good shit. What I wanted to point out is if they ask you, it has less iron. There's less iron in breastfeeding, but it has a higher bioavailability. So that's the first thing. So if they ask you like quantity wise, it's less. Same thing about this calcium and phosphorus and shit. It has less quantity, but it has higher bioavailability from those roots. The reason I put this up is I wanted to point it out this shit. So generally we don't supplement iron. I don't know what they do actually in the United States, but guidelines say don't supplement iron if they're born at term. Only supplement if preterm. So this is kind of a very subtle difference. Like they'll ask you what should we give to this kid, yada yada, and they'll be like vitamin K, yada yada yada, vitamin K, vitamin D, iron. Only choose iron if the kid is preterm. If the kid isn't preterm, don't supplement iron that early. This is like there's like controversy about this, but just remember that we supplement vitamin K, vitamin D, maybe calcium a bit. We don't supplement iron if they're term, only if they're preterm. Just something, a good snippet. Let's move forward. Okay, you probably know this. I'm not even going to say this. Just remember, OCPs decrease protein content. That's why they're contraindicated. There's no actual other reason why they're contraindicated, but just don't give OCPs. And if they're on lithium, cyclosporin, amphetamines, or glutamines, bromocriptine, just don't give it. The reason I'm pointing all of this out is you probably know that table in UWORLD, which says that the conditions mom has and the conditions the babies have and whatnot to give. Like this is just an addition on top of that. Okay. Lithium, again, talking about lithium obviously causes tricuspid atresia. We say it causes atrialization of the right ventricle, whatever. You need a shunt for lithium okay, think about it this way. If this valve doesn't exist, if this valve doesn't exist, how the hell is the baby alive? There needs to be a shunt. So the shunt is generally an interatrial shunt, an atrial like septal defect, if you will. And then if you think about it, the blood's going here, the blood's going down, and the blood's going to the body. I don't really know how blood gets oxygenated to this shunt here, the interventricular shunt. But like if you think about it, right, right heart's getting really big. So the left heart's getting really big. So just remember that tricuspid atresia has a left axis deviation with an ASD. Just think about it on your own. And these are shit that you will find. You will find like left axis deviation shit. And then the second thing is you will find right atrial enlargement. And then third thing you'll find because of the right atrial enlargement, you'll find the tall P waves. That's just the reason I put this here. So think about it. Think about it on your own. Okay, let me see if I'm missing something, guys. Aha. Okay. Also, the thing I'm missing and not telling you guys, right, is that the lithium-induced tricuspid atresia causes all the stuff I just told you, and it also causes a widely split S1 and S2. That makes sense because there's an ASD, plus a loud S3 or S4. I'm not exactly sure the reason for why that's happening, and it also causes a holosystolic murmur at the left lower sternum border, which is the murmur of the ASD. So just remember loud S3, loud S4, and then if they give you an ECG, you can kind of like look at it if you're good at ECGs. This is just an ECG showing left axis deviation. I'm not going to get into how you figure out left axis deviation for you. Generally, you're going to look at like an R greater than S, like in V1 and AVF. Just remember for axis deviations, you're looking at one AVF, sometimes lead two, but one AVF. We're not going to get into this right now. That's just like two. That's just two out there. The step 2 is never going to ask you to do this. Okay. Let me clear my screen. Okay, this is the shit. You can pause this, look at this, man. They love this shit. In step 2ck, this comes up a lot. I just want to point out a few key ones. The ones that I want to point out, right, are the Down syndrome with the congenital AB septal defect, like the outflow tract abnormality, Turner syndrome with the bicuspid recurrent coarctate aorta, Williams with the supravalvular aortic stenosis, which is the murmurs a little bit higher, but it's still going to radiate, yada yada. The 22q11 with tetralogy of Fallot, they love this shit. And the next thing I wanted to say is Fragile X also causes mitral valve prolapse. So like Marfan causes mitral valve prolapse, and Lozano's causes mitral valve prolapse. Marfan also causes aortic root dilation, and then Fragile X is associated with mitral valve prolapse. Anorexia nervosa is also associated with mitral valve prolapse. That's a fact for you. Okay, next. Okay, the thing is, man, everyone knows congenital hypothyroidism. Just remember that the cause is aplasia or hypoplasia of the gland itself, and this is the treatment. So, like, don't choose arrested development, yada yada yada, or arrested migration of cells. Just say aplasia, hypoplasia of the gland, dysgenesis, right, is the cause. That's what they're going to want you to choose. Don't choose anything else. And this is the dose to treat it. I don't know if you guys want to hear that, but that's what it is. Okay, this is laryngeal papillomatosis. Just treat is surgery, right? Debride. They're going to put in the option interferon, whatever, podophyllin, whatever. Don't choose that. Just debride this. And this is 6 and 11, right? This incidence is decreasing because like Giardia, like whatever that the HPV vaccine that has 4 strains, that's decreasing incidence of this in moms. So kids aren't getting it, but it's 6 and 11, right? Just you want to remember that. And those are the non-cancer causing ones. Okay, man. Next. Okay, man. Just this is gonna suck, but you gotta know this if you want to be cool. The thing is, right, that orotic acid. So there are 2 instances in medicine where you're gonna have high orotic acid in the urine, right? There is ornithine transcarbamylase deficiency and hereditary orotic aciduria. Ornithine transcarbamylase deficiency, if you guys remember from biochem, is the enzyme right here. It's turning carbamoyl phosphate into orotic acid. This orotic acid is then going on and just doing its shit, right? If you don't have this enzyme, right? I probably said this wrong. The point that I'm trying to make is ornithine transcarbamylase deficiency, you don't have this enzyme. If you don't have this enzyme, I'm going to clear this section. If you don't have this enzyme, your urea cycle, which is this thing over here that you guys probably recognize, doesn't work. If your urea cycle doesn't work, you will have no urea. So you will have low urea. So like when the urea cycle doesn't work and in this enzyme problem, you're going to have low urea and you're going to have low blood urea nitrogen. You're going to have high orotic acid and you're going to have no megaloblastic anemia. That's the point I wanted to make. There are 2 instances where you have megaloblastic anemia. This ornithine transcarbamylase deficiency and orotic aciduria. In orotic aciduria, you're going to have the exact same thing that I just said. So like the urea, you're going to have low urea, low BUN, hyperammonemia, and in orotic aciduria, you will have megaloblastic anemia, and this you won't have megaloblastic anemia. That's the point I was trying to make. I fucked it up, but it's okay. Just you can pause this and look at this. This is kind of what I was trying to explain, but I didn't explain it very well. Okay, chlamydia causes staccato cough. So chlamydia, obviously the ABC of chlamydia causes the trachoma. Remember, for the trachoma, like the eye shit, you're going to treat the entire village. You're going to treat everyone, basically. You're going to treat everyone in that group of people, in Africa. For this is serotype T2K. It causes all of this stuff, which is what we normally think it causes. And just remember that it causes this pneumonia with staccato cough. I'm not going to explain to you what staccato cough is. It's just like a weird ass cough. I think it's the cough where they like cough, 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 inhale. That's like the inspiratory cough or whatever. I don't know. I think they cough, inhale, cough, inhale, cough, inhale. That's staccato cough. But it causes staccato cough. It's a weird type of cough. Just know it. Okay, that's everything for you guys. Peace.